Welcome back. So today we are super excited. We have a special guest with us today. We have Rebecca Milman. And if you have not heard of her, this is probably your first day of X-ray school because that's really the only reason why you haven't heard of her. She and Michael Solowski are making headways in changing how we do radiation and radiation safety. We are looking at how effective uh, shielding is and realizing that perhaps it's not as effective as we used to think it was.
If we talk about, the cancer risk from diagnostic imaging, does it matter if the risk is zero or if the risk is really, really low? And the reality is we may not ever know the answer to that question. Right. But what we do know is that if there is a risk, it's very, very, very low. And does whether the risk is low or non-existent, does that even really affect how we look at risk benefit when it comes to patient shielding? And those are the sorts of things that we really were trying to ask ourselves and really kind of pare down and say, okay, well, why are we continuing to do this? Why did we start doing it? What has changed since then? Yeah. And look at it sort of from that standpoint. Every single position statement, certainly anything that I've ever written or presented, I try to make it very, very clear that we are talking about not shielding patients by default. We're not talking about never shielding a patient. And I think that even with my limited time in the clinic, and I certainly don't have the patient interactions that radiologic technologists do, but I think everybody recognizes that one, patients should have some say in this, and two, that there are scenarios where shielding an individual patient may be in the best interest of that patient, but we should recognize as a medical imaging community that benefit is psychological, and there is sometimes that can be a very huge benefit, but that it's psychological and not because of any actual benefit that they're getting because of radiation exposure or not, or whatever. From the very beginning, we talked to the technologists, and because they're like, well, what if the patient really wants to be shielded? The response has always been, shield them if you can. Now, if you're doing a C-spine x-ray and they want a thyroid shield, well, then no, you're going to have to tell them, no, we're not going to do that. But if you're doing a foot x-ray and they want a lap shield, fine. The idea is that we're not doing this by default, and we're educating people as best we can. Not that we're just going to say I refuse to shield you.
The one thing that I thought was interesting, so I was there when we were doing that whole transition, and I was surprised how many people didn't ask. Like, they just assume that you have their best intentions in mind, which you do. And I was very nervous to start not shielding. It was a big deal. And especially with the research coming out that was like brand new at the time. And I was like, well, what do I tell patients? What do I do? And it actually was really easy. It was just not shielding. And I did have occasionally a patient ask. And again, it was we were provided information on things to say. They didn't have the pamphlets available right away, but eventually they did get us like little brochures that we could have a script and know what we should say. So we had the right wording down. But yeah, it actually was way easier than I thought. And it's crazy. In the last episode, we were talking about how when I started radiology like 15 years ago, you had to have the lead in for a chest x-ray, and how many times I had to repeat because I clipped the bottom of the chest because I was trying to have the patient's best intentions in mind. And now I feel horrible that I ended up doing a whole bunch of repeats, probably had more dose with the AEC and all of that. So it's actually interesting, like how much has changed just in 15 years, 10 years.
Well, first of all, I want to say you shouldn't feel bad at all. And I say this seriously because, especially if you look back at why people started shielding and why there was a big push in the 1970s to It was a recommendation. It was never a requirement, but it was a recommendation by the FDA to use gonadal shielding. There were reasons for that.
Mm-hmm.
And so that was what people thought was best based on the evidence that they had on the time and based on the technology of the time. But then things change. Our knowledge of things change, our technology changes, and so it makes sense to periodically reevaluate a lot of these practices.
Well, I want to put you on the spot then and ask you if you, Rebecca Milman, were about to do an x-ray on a patient, on me, let's say, and I don't know anything about all this stuff, and I say, why aren't you using the shield? What would you say to me? How would you explain it to a patient?
So I'd explain it and say that our hospital recently changed their policies after reviewing all of the most recent scientific literature, and the benefits that we thought shielding provided no longer, they don't have the same benefits, and there's some risk introduced.
Oh, okay. I like that. So go back to benefits versus risks and emphasize. Yeah.
I think the whole discussion really needs to focus, whether we're talking to patients or whether we're talking to other medical professionals, really should be focused on benefits and risks. Because the reality is, if I use gonadal shielding, and then there's no denying the fact that if I use in-plane gonadal shielding, that it will reduce dose of the gonads. That is absolutely true.
Right, certainly.
But that's only part of the story.
Yeah.
And that's, I think, where we really need to put it in perspective is in really how my internal dialogue, and when Mike and I discuss this is exactly the conversations we have are, okay, well, what are the benefits that we get and what are the risks? And when we talk about benefits, the other thing that's really important to keep in mind is that a lot of the time it's very tempting to say, well, if we use gonadal shielding, we get a 70% reduction in dose. And we also have to look, though, at what those absolute doses are. And I use the example at some point, and it's kind of like if there's a new diet soda that comes on the market and they're like, hey, we have half the calories of the previous diet soda. Well, if that previous diet soda had 500 calories, maybe that's a substantial change. If the previous soda had 2 calories, and now, okay, well, it's still a 50% reduction. And some people will say, well, any decrease is good. Decreasing your caloric intake is good by any means. And if that's the only part of it that you're looking at, that may be the conclusion you come to. But if you also talk like, well, but it tastes really bad, it gives you massive diarrhea, whatever it may be, you also, you have to look at all of these things, and each individual person's, the conclusion they come to may be different. And for patients, that's, that's more acceptable, but it's also very difficult for them to make that risk benefit evaluation. But if we look at the benefits provided by shielding and also look at the risks, that's really what it comes down to is comparing those. And at the end of the day, I'm convinced that the risks associated with shielding patients is, in most situations, is much higher than any associated benefit.
Yeah. Well, there you have it. Like Rebecca Milman, she's not a monster. Like she actually cares about human beings.
Well, so I will say this too, and along those lines, because yes, I want to acknowledge that psychological aspect. And I mentioned that, that the risk benefit for most patients. And of course, the exception to that, we all know that there are some patients who are very nervous, very anxious, who for that particular patient at that particular moment, a shield may provide enough of a psychological benefit and decrease the anxiety to improve the outcome of that exam. And I think the AAP position statement says it more eloquently than I just did, but it says essentially the same thing. We all recognize that, which is why this had never been a thou shalt not ever shield. But one thing that really has driven that point home for me on the psychological benefits is an experience that I had with my daughter. So she's a perfectly healthy, almost 12-year-old now. But when she was 5 or 6 weeks old, they were concerned that the portions of her skull were fusing prematurely. And so they ordered some skull x-rays. So I'm in there with my 5-week-old daughter, and the tech is setting up the exam, and I'm in there holding my daughter. And I have this wave of guilt and absolute fear wash over me. And I'm thinking, am I doing the right thing? Should I be having these x-rays done on this little baby? And then a moment later, and I thought, okay, Rebecca, you of all people should know better than to be freaking out about this. But it has forever changed how I talk to patients and how I talk to people about this, because there is a very legitimate and very real part of the human brain that has those emotional responses.
Right.
And we have to acknowledge that and respect that, while still saying, okay, well, we shouldn't be basing all of these decisions on emotion. We should be aware of it and respect it, but that should not drive clinical practice.
Well, thank you so much, Rebecca. This has been amazing. We appreciate your time, and thank you for helping us educate the radiology community.
I'm happy to help. And also, if there are, members of your audience who have questions, suggestions, comments, as long as you're not telling me that I obviously hate babies and that my goal in life is to fry babies, because it's not. Really isn't. And it's funny, my kids always think that's hilarious too, because they're like, but you love babies more than anyone I know. I'm like, I know, but I'm happy to, I think these are important conversations to have. And again, if people disagree with me, that's fine. That's, it's not about being right. It's about trying to have these conversations.
Perfect.
I'm kind of secretly disappointed that we're not going to have Godzilla. Like, there's a part of me that's like kind of secretly disappointed about that.
I think there are a lot of people who are.
Yeah, but I'm keeping it to myself. If I just said that out loud, I'm sorry. But thank you again so much.